We're going to get started with the second panel. Let me briefly introduce all of our panelists while Andrew moves to the podium. Dr. Andrew Forsyth is Senior Science Advisor in the Office of HIV/AIDS Policy and Infectious Disease Policy at the U.S. Department of Health and Human Services. Dr. Amy Lansky, who was just referred to, is Senior Policy Advisor in the Office of National Drug Control Policy and in ONAP, the Office of National AIDS Policy. Dr. Amanda Castel is an Associate Professor in the Department of Epidemiology and Biostatistics at the George Washington University School of Public Health. And Mr. Jeffrey Crawley, who is currently the Distinguished Scholar and Director of the O'Neill Institute at Georgetown Law School and former Director of the Office of National AIDS Policy at the time when the initial HIV/AIDS policy was released. So what we're going to do is first hear from Andrew and Amy, and then take some questions related in particular to the indicators. And all I will say about this is that in Douglas's rapid-fire presentation a few moments ago, hopefully what you took away as a top-line message is that the foundation of the National HIV/AIDS Strategy has not changed significantly from 2010 when it was first released, but because of these advances in policy and in science that you've heard referred to repeatedly this morning, what this updated strategy does is fine-tune our actions. And certainly it extends the strategy to 2020. But having said that, in terms of fine-tuning, one of the important areas in which the updated strategy was finely tuned was in the area of its indicators. And so we're going to have a little more discussion about that, first from Andrew and then Amy. Andrew?
Thank you very much. It really is an honor to be here among all of you, my friends, my colleagues. And in particular, I'd like to just thank you for the honor to present some of the work that we have been doing over the last 6 months to develop new indicators for the National HIV/AIDS Strategy Update. And in particular, what I'll do today is I'll just take a few minutes to provide or introduce you to the new indicators and the targets. And then I'll also turn over the podium to my colleague, Amy Lansky, who will review the progress we've made according to those new indicators. Before I jump into the presentation, though, let me echo the acknowledgments of Mr. Brooks' inspired leadership. He's been a fantastic person to work with. And let me also acknowledge Amy Lansky, who really, you may not know it, who really was central to a lot of the work that we've done, not just on the indicators panel. Finally, I'll point out that we wouldn't be here if it weren't for the likes of Jeff Crowley, Greg Millett, who's here today, Adele Simmons, and others who created a foundation for us to build on that really was solid. So let me just acknowledge all of those folks now. So what I'll do is I'll just give you a quick overview of what we'll talk about. I'll say a word or two about the subgroup that we worked with, our charge. I'll say a word or two about the indicators and the targets themselves. One reason it's important to cover this topic is because it's great to have action items. What really is critical, certainly from my perspective, from many of our perspectives, is to have measurable indicators, things that we can use to keep ourselves accountable. I'll say a word or two about some of the issues and considerations that we raised and grappled with. And then I'll turn over the presentation to Amy to give you an update of where we are in terms of our progress. As Douglas mentioned, and others as well, we wouldn't have been here without a true collaboration across the federal government. You can see some of our partners here from CDC, NIH, HRSA, Antigone Dempsey is here. Renee Stein is here, whom I haven't met yet, but she helped us dig through the data. Patty Dietz as well. We wouldn't have been here without the hard work of our many CDC, HRSA, and other colleagues. In January of this year, Douglas established the data subgroup and gave us a very specific charge. He really wanted us to look through the data to evaluate the different strengths and weaknesses of various data sources that could be the basis of new indicators. He wanted us to review the data with a particular eye on specific groups as defined by age, race, ethnicity, sex, transmission mode, and even geography. He urged us to determine which indicators from the 2010 strategy to retain, to revise, or to drop. And he urged us as needed to develop new indicators. And of course, I'll present those to you today. He asked us to recommend annual as well as 2020 targets, and we worked at length, at considerable effort really to identify those. And I think we really have something that we can be proud about. Ultimately, he urged us to keep the indicators to 12 or fewer, and we'll see if we actually accomplished that. We did, but we fudged it a little bit. Let me just say that, as PhDs and others, we always think about criteria and objectives. When we approached this process, we said, well, for the indicators, we wanted to make sure that they were all directly relevant to the strategy goals. They should reflect the latest science and policy and practice. They should provide us measurable outcomes, not of processes, but of outcomes we can sink our teeth into. Likewise, the data we wanted to focus on really needed to be nationally representative in a way that in some respects aren't always in other cases. They needed to be routinely reported, timely. They needed to be comparable across years so that we could see how we were doing, how we could measure our progress, even going back to 2010. And importantly, they needed to be able to be stratifiable, again, by the groups that I described earlier. And very importantly here, and we'll talk a little bit about this later, we really wanted indicators that could be used at the state and other levels to gauge progress toward achieving the goals of the National HIV/AIDS Strategy. The measures we selected needed to have face validity in the sense that we wanted them to measure what they purported to measure. And importantly as well, we wanted them to be simple and reasonably accessible to a range of audiences. Our objectives, all told, were to refine the range of indicators that were being used, refine the scope of them. We wanted to, again, align with the data, the science, the practice. We wanted to set bold targets where we could. And we wanted to improve disparities monitoring. I think in that respect, we really did a nice job. Finally, and perhaps most importantly, Amy Lansky was our real advocate for this point, we really wanted to inspire action, continued action. We've made incredible progress. There have been incredible developments, but we need to push on further. So let me jump right into the indicators themselves. Some of these will be familiar, others will be new. So the first indicator that we settled upon was that we really should work to increase the percentage of people living with HIV who know their serostatus to at least 90%. Bear in mind as I go through this that there are parallels, that are nice parallels, I should say, with the UNAIDS 90-90-90 initiative. The second indicator that we identified was that we would reduce the number of new diagnoses, this is an important change from the 2010 strategy, by at least 25%. A bold target, a bold goal that ultimately will be influenced by all the other steps in the continuum that we're working toward. The third, we would reduce the percentage of young gay and bisexual men who have engaged in HIV risk behaviors by at least 10%. This is a new indicator, and if you're following the data closely, as I know everybody in this room and everybody out there in the internet are doing, you know that young gay and bisexual men represent one of the groups where we've seen new rising HIV infections. So it really is important to find a way to track what's happening for them. Fourth, we wanted to increase the percentage of newly diagnosed persons linked to HIV medical care within 1 month. Remember, the original strategy called on us to do this within 3 months. And we would do that to a level of at least 85%. Indicator 5 will increase the percentage of persons with diagnosed HIV infection who are retained in HIV medical care to at least 90%. Again, bear in mind the UNAIDS 90-90-90 initiative. We would increase the percentage of persons with diagnosed HIV infection who are virally suppressed to at least 80%. This is everybody. This isn't just African Americans and Latinos. This isn't just MSM. It's everybody. We need to get to these goals. And these three are, in my opinion, among the most, are among the boldest goals that we're setting here. For us to get to these targets, we're going to have to continue to work at the federal and non-federal levels in a concerted way to really achieve this. But I know that we can. In terms of homelessness, we want to reduce the percentage of persons in HIV medical care who are homeless to no more than 5%. And we want to reduce the death rate among persons with diagnosed HIV infection by at least 33%. Again, that last indicator is a new one. We think it will help us to track the overall quality of care that people receive once they're diagnosed. Two more that I want to point out to you. These are the disparities indicators that took us months to really settle upon, but I think we're really proud of them. First, we want to reduce the disparities, right? Previously, we talked about the numbers. We want to reduce here the disparities in the rate of new diagnoses by at least 15% among these groups: gay and bisexual men, young black gay and bisexual men, black females, and people living in the southern part of the US. I'll tell you in a minute how we got to these, but I just want this to sink in for a moment. In addition to reducing the overall numbers of diagnoses, as you'll recall from indicator 2, we really want to shrink the disparity, the difference between those given groups and the overall population. We want to shrink those rates. And then finally, the last indicator we have here is that we want to increase the percentage of youth and persons who inject drugs, in particular, who are living with diagnosed HIV infection. We want them to be virally suppressed to the level of at least 80%. 80% of those folks should be virally suppressed. And these are the goals that we've set for ourselves by 2020. Let me just say a word or two about some of the issues we grappled with. The UNAIDS 90-90-90 initiative grappled with this. We grappled with it before with the 2010 strategy. The question is, how do we set annual goals? Well, we took a lesson from some of our CDC colleagues, and we decided we had a number of different approaches that we gave careful consideration to. But what we did ultimately was we recalibrated all the targets using these updated indicators. We went back to 2010 and we said, well, if these are the indicators, if this is how we're going to mark our progress for this entire 10-year period, let's start here. And the reason we wanted to do that was to be sure that there was comparability, continuity, as we went through that decade. We also made an assumption that it might take time, or it would take time for us to change the direction of this ship. That in the first couple of years, as the federal government and as our non-federal partners started to retool how we all work together, that we might see less change initially. But over time, we would start to see the slopes increase. And that's what you see here in this very simple table. We made the assumption that in the first few years, if we look back, we should probably only expect to see 5% or so change in the first 3 years. We then reasoned that it made sense that as we started to gain momentum, that we should start to see change at a faster rate. In other words, between the years 2014 and 2017, we might expect to see 10% of the overall change we're looking for the period to occur in those years. Likewise, for the last 3 years of this strategy, 2018 to 2020, we thought we should expect to see about 15% of the overall change in those last 3 years. Now, there are some pros and cons to thinking along these ways, and trust me, we wrestled with this for a long time. The pros, of course, were that the targets were going to change gradually. We give ourselves a little time at the beginning to reorient, to refocus, and then to step on the gas. But the cons are worth noting as well. So it's hard to predict, for example, what new activities will need to be implemented in order to reach these goals. It also assumes that resources will be sufficient to do so. And finally, notice, 45% of the overall change that we're predicting should happen in the last 3 years. That's a lot of backloading. It means we really, really have to step on the gas. We've done a fantastic job in many respects, but to achieve these goals, we're really going to have to work in a concerted effort in the way that we have, but even at a higher level. I'll say a word or two about our choice to use diagnosis data versus incidence data. I'll just say this very quickly. We'll probably have a question or two about this later. But we preferenced diagnosis data for a couple of reasons. They're published annually, they're robust to estimation changes, they're robust to new testing technologies, and they're available and stratifiable at the state level. For us, again, we didn't just want to look at the national level, we wanted to look at how we were doing at the state level with these core indicators. Incidence data are fantastic, they're incredibly useful, there's no doubt about it, but in many ways they didn't offer us the level of flexibility we needed. I want to wrap up by saying just a few quick things about how we selected the disparities indicators and a few other things. First, people will ask, how did we arrive at these groups? Well, we took a look at the data, and there were mountains of data for us to sift through. We focused on the different indicators, and we started to look at the different groups that I noted earlier. Those groups that had large numbers, 1,000 cases or more, we really wanted to focus on those because we knew those numbers were more likely to be stable than smaller groups' numbers. And we focused on rates in particular where they were above or below average for the whole population. We said, well, who has the most room for improvement, and how do we focus our attention there? Finally, I'll just remind you, and I think I mentioned this earlier, that in addition to reducing the overall numbers in new diagnoses, we're also trying to narrow the disparities. Again, the difference between any particular group, the 4 that I identified earlier with respect to diagnoses, and the overall population. So there are really 3 or 4 things working at the same time that became a little difficult to predict, but I think this is a really important goal because not only are we going to reduce the numbers, we'll also shrink the disparities. Finally, I'll just point out that for the final indicator on viral suppression for youth and people who inject drugs, it's important to note that we wanted to focus on this group because we wanted, of course, everybody to reach a level of viral suppression. We wanted 80% or more people to achieve viral suppression, but we knew it was critically important to improve the numbers for youth and people who inject drugs. Along the way, we wrestled with a number of other indicators that we might use. We realized, again, using the criteria that we had, that we didn't quite have the data that we needed. We didn't quite have all of what we needed to measure things like HIV stigma, like uptake of pre-exposure prophylaxis, of HIV diagnosis among transgender women. The strategy, as you'll see when you get a chance to read it, really emphasizes the need to address the needs of these, or to address these issues in particular. And ONAP is committed to developing indicators and data sources, or identifying data sources that can be used to track how we're doing on these particular topics. With that, let me turn the podium over to my colleague Amy Lansky, who will provide you an update of the progress we've made since 2010 in cases where we have the data.
Thank you, Andrew, and good morning, everyone. I will quickly add my thanks to all of you for being here, to our live streamers, and in particular to our work group for the indicators, as well as our technical consultants who provided some really important feedback to us along the way. I guess I'll just do that. Yeah, okay, so I'm gonna talk about our progress on these indicators, and I'm gonna be going through a number of tables that look like this, so I wanna orient you to the table a second before I start. So on the far, whoa. What do I do? Mouse, switch. There we go. Back a few, please. Am I supposed to be doing something, Matt? Sorry. I need to go back about 3 slides, please. All right, and then just go forward. Great. That's fine. Do I have a pointer too? Okay, so we have the, sorry about that. We have tables that show our progress on the indicators. On the far left, we have what the indicator is. Does that work? Yes. Then we have our data. These are the actual data on the indicators. 2010 was our baseline. We have data for 11, 12, and in some cases 2013. In terms of our targets, as Andrew mentioned, we have annual targets for each year, and so what we're seeing here is what was the target for each of the most recent years, our 2020 goals, and then our indicator of progress. And what you'll see here are our color coding, which is green where we have met or exceeded the annual target. We have yellow for where we're heading in the right direction, but we haven't yet met the target. And then we have red where we may not be going in the right direction. So here we have knowledge of status, which you can see has been increasing since the baseline. We have exceeded our annual target And so we have a green light on that one. New diagnoses are indicators to reduce the number of new diagnoses by 25%. We are in fact meeting our annual targets in those reductions. We have the asterisks there for some of the diagnosis data. We wanted to provide the preliminary data, but our assessment is based on the most recent year that's not preliminary. So here we're assessing for 2012, but wanted to show where we're preliminarily heading for 2013. And then in terms of the measure of risk behavior among young gay and bisexual men, this is a new data source for us. Questions were added to the Youth Risk Behavior Survey in 2013. So that's essentially serving as our baseline, and we can't yet assess progress on that one. Here we have linkage to care, retention in care, and viral suppression. For linkage to care, we are in fact making increases, and I will note that we have changed this measure from being linked to care within 3 months to being linked to care within 1 month. And even with that more ambitious linkage, we're still seeing progress towards increasing the proportion who are linked to care within that 1 month time frame. Retention in care is an example of one where we're heading in the right direction, but we haven't yet met the target. So more push in this area is going to be needed to continue to meet our annual goals. And for viral suppression, we are also seeing increases and have exceeded the target for 2012 in that area. Our indicator for homeless is one where we have that red dot sticking out there, indicating that in fact we've seen small increases in the proportion who are homeless. And this is during the period 2010, 11, and 12. And as we saw that and we started to think about why that might be, in looking at some other data more generally on homelessness, we have seen as a nation higher rates of homelessness that are still, during this time period of 2011, 12, and 13, higher rates that are still kind of a residual from the economic downturn in the earlier years. Our death rates are decreasing, so this is a rate that you see here per 1,000 people living with HIV, and that is going down, and we have exceeded our annual target there. For our disparity indicators, just to reiterate what Andrew said, what we're looking at here, that number is a ratio for the disparity among the particular group compared to the overall rate. And to reduce our disparities, we need to reduce that ratio. In fact, what we're seeing for gay and bisexual men and for young black gay and bisexual men is that those disparity ratios are increasing. And so we really need to address this issue and work in these populations, as you've heard all morning so far, that these are really critical groups for us to address. The good news on this slide is we're seeing reductions in the disparity ratio for black females and also in the southern United States. And finally, our viral suppression indicators for youth and for persons who inject drugs, we are meeting our annual targets on those. And I will reiterate that, as Andrew pointed out, our annual targets are about to get harder to meet. That proportion that we need to reach for each year is about to go up. So I think we have a good picture now, and I think that we need to kind of fasten our seatbelts and get ready to push so we can make our indicators. This slide was put in just to illustrate kind of how that incremental progression will go. So on the top dark lines, you see our baseline values, then we have our current values, the 2015 targets, and then the 2020 targets. So we're really looking for that incremental progress, but there are a number where we are making progress, and that's great, and we will have a bigger push for years to come, which is why we have our strategy, right? It's our roadmap. It's the way to lead us to be able to make the changes necessary so that we reach those targets, and those are targets that indicate that we're having an impact on HIV in this country. So this is our summary schema for how we're doing. We see that we have some mixed progress. We have a number of indicators where we're meeting our current annual targets. We're moving in the right direction with retention. A few need improvement, and we also will need some more data. And so then to just summarize here, so our update includes our new indicators that build upon the precedent. They do have bold targets, and they were created to inspire the action. And we've had discussions, sometimes we get focused on the indicators and meeting that target, and the indicators are there to help us guide the way. We don't do this to meet the indicators. We have the indicators to kind of keep us in check and make sure we're making progress in the right direction. Our progress so far is mixed, but encouraging, I think. And with persistence and focus and optimized resources, we will be able to reach our targets. Thank you.
Thank you, Andrew and Amy, both for explaining the indicators to us, and Amy in particular ending by reminding individuals that the indicators are really what we use to figure out where we're going and where we need to improve. I know sometimes in public health folks think we're obsessed with numbers, but the point is that the numbers are there to drive action. Also, as a public service announcement, I wanted to note, in addition to the panelists, the federal participants that Andrew showed on his slide as having informed the indicators development, I also want to recognize the various members of the Presidential Advisory Council on HIV and AIDS who have been very engaged on the issue of how we should best monitor progress in the ongoing implementation of the National HIV/AIDS Strategy. And I think Douglas even mentioned that some of the indicators and some of the timeframes were directly influenced by input from PACHA, as well as what we heard collectively when we met with communities in various cities across the United States. The last public service announcement is just to let the audience know that this particular panel, since we're obviously running over, this particular panel will end no later than 1:45. So having said that, panelists, you know now I'm going to ask you some questions, and it would be very important for you not only to answer the questions, but to answer them succinctly. So, Amy, I'm going to begin with you, and I think Andrew alluded to this, and certainly many of us in the audience recognize that one of the major changes in the indicators was the movement from looking at estimated incidence, in other words, the estimated number of new HIV infections, and instead of using that now, what we're actually using is diagnoses. And I think that can be confusing to folks, particularly if you all were paying attention and you noted that we have one indicator that says we want to do a better job of identifying people who are infected so we can get them into care, which would mean that we're driving the rate of diagnosis up. But when we think about overall trends in our activities, we eventually want to see, since it's a surrogate for new infections, we eventually want to see the number of diagnoses go down. Right. It's a little hard to wrap one's brain around. So we're going to give you that brain teaser, Amy, if you can tell us a little bit again about why that change and how we interpret it.
Okay, I will do my best. I first want to reiterate what Andrew said, which is, the incidence data are important for us as a nation to monitor how we're doing, and this is an issue about indicators, and indicators are developed to monitor how we're doing year by year and to have things that are stable that we can look at over time. And so we know that the HIV incidence data, really still being relatively new, has changed a lot over time, and in a lot of good ways. So we have new HIV testing technologies that have affected how we can be doing HIV incidence estimation. The statistical modeling that's been done and the use of the data to make those estimates has been refined over time, and those will continue to change and to be improved over time. And that's great, and that doesn't necessarily make for a good indicator. Those changes over time make that a little bit difficult. In contrast, our diagnosis data are published in a routine and standardized format, and they're available in every state. And as Andrew mentioned, one of the things that we were interested in is having indicators that can be followed as well and measured at the state level so that we can see across the nation how we are doing. So given the advantages for the purposes of indicators, we chose to use the diagnosis data. But as Dr. Valdiserri pointed out, that was not without recognizing some challenges. So first, we have to understand our diagnosis data with consideration for trends in testing. And because you could see changes in diagnosis that are not just related to new infections. So if diagnoses, for example, are decreasing, you need to look and see whether there are fewer tests being conducted, whether those tests are being done on people who are at lower risk for HIV, or in fact, if it's a good indication that our new infections are decreasing. And second, as Dr. Valdiserri pointed out, we do have this tension between wanting to increase the proportion of people who are diagnosed, which means you want diagnoses to go up, but also reducing diagnoses as a way to lower the burden of disease across the nation. So initially, what may happen is that as we do improve on that proportion of people who know their status, you could be seeing increases in diagnoses before they go down as we push to reduce new infections. But in the longer term, diagnosing people who were previously undiagnosed, getting them into care and on treatment, increasing the proportion who are virally suppressed and reducing the probability of transmission will in fact reduce the number of new infections and will be reflected in the number of new diagnoses going down as well.
Thank you, Amy. I'm going to ask a second question now. Amanda, I'm going to pose this to you. And it is still in the domain of the indicators, but I want to hearken back to what Douglas reminded us earlier, that the updated strategy is not a federal plan, it's a national plan, which means that everyone in this audience needs to be able to use it and find it useful. And Amanda, although you are employed full-time in academia, we know that you're doing a lot of work with the Washington, D.C. Department of Public Health. And I wonder if you could share with us how you think the indicators that we heard about from Amy and Andrew will be used at a Department of Public Health level, recognizing that local and state departments of health are key implementation partners and really need to be able to track what's going on with the epidemic. Amanda?
Sure. And I just want to start off by saying thank you. Thank you to Jeff Crowley for laying the foundation for the strategy, to Grant Colfax for adding the continuum of care measures, and to Douglas Brooks for moving us forward and and helping us further achieve these goals. And thank you for inviting me to add my comments today. So I think that the strategy and the indicators are extremely helpful and invaluable in guiding our efforts, both at a local, a regional, and a national level. It really helps us focus on a few key distinct areas in a standard and consistent way that's also comparable. So I think it's really important that when we were looking at these indicators and advising the group a little bit on what to put forward, that we continually said this needs to be something that can be measurable at a local, regional, or national level at the health department level. In DC, we've been annually benchmarking the progress that we've been making. It's been extremely helpful in helping us understand the programmatic impacts that we've made, where we've had successes, but it's also helped us to identify where there are gaps and to figure out how we can use new and innovative ways and strategies to really try to narrow down those gaps. And then, of course, going forward, there are these new indicators that we will now be looking at, again, at the local level to see where we stand and to see where we need to make improvements. I think as a researcher, it's really important also that we use the data that we collect for our various research projects, that whether that be clinical data, cohort data, to be able to also drill down a little bit further. So it's useful to be able to access surveillance data, but sometimes cohort data, such as NA Accord data, for example, can help us to drill down, to look at churn, to look at the continuum of care, to look at aging, antiretroviral treatment, et cetera. So I think that the research component is really important, and the data that go along with that are really important also in having a full picture of what's happening with the strategy.
Thank you, Amanda. And of course, although it's not been explicitly mentioned, I think that all of us understand and embrace the importance of transparency, especially when we're talking about public funding. And I think that one thing that good indicators will do is obviously not only drive program, but also help us explain to various stakeholders and policymakers where we're doing well and where we might need additional support. The next question, Andrew, is for you. And I know we collectively have talked about this a great deal internally, but I want to go to the issue of the measurement of disparities in the updated strategy. And in particular, I know you covered some of this in your slide, but in particular, if you could speak more to how the particular groups were selected, and I want to underscore this because it's a very, very important and. How do we monitor progress in other groups that don't have a specific indicator and at a national level may not have a great burden of disease, but at a community or a jurisdictional level might have substantial disease? So if you could talk in particular about why we chose those groups and how we can monitor progress in other groups, other racial and ethnic groups, other minority groups that aren't explicitly spelled out in the indicators.
Sure. Well, let me take the last first, if I could. You know, we hear all the time that the epidemic, responding to the epidemic really requires us to take a look at what's happening locally. Obviously, we're taking a national view, but we selected these indicators in part for their capacity to help us evaluate how we're doing at the state, city, local levels. We think this is critically important, and in that sense, we know that the response to the HIV epidemic has to be driven by the local epidemiological profiles. So we fully expect that in implementing the National HIV/AIDS strategy, that people look closely at their local data, and they use those data to target their responses. Now, in terms of thinking about how to track changes in the disparities that may be locally defined or that may vary by locality, I think we offer a nice example of how you might think about closing the gaps in disparities that you find locally. The nice thing, there are many great things about the strategy in my view. One of those is that there will be technical appendices, basically an indicator supplement that will be published shortly, that will provide all the detail about how we conceptualize these indicators, what the numerators, denominators are, what the data sources are, and how we went about calculating the disparities themselves. That same method could be used to develop indicators that allow you to measure whether or not disparities are changing, hopefully in the right direction, for local epidemics. So I think the methodology can be used even though at the national level we really are urging us all to focus on closing disparities for men who have sex with men, young black men who have sex with men, black women, and also people who, people who live in the southern parts of the U.S.
Thank you. Jeff, I'm coming to you at the very last question, but before I do so, Amy, a quick question to you, not an easy one, but a quick one. You did show us, you showed us a summary at the end of your presentation about a snapshot, as it were, of how well we're doing, and gave a caution that making additional progress might be more challenging in some domains. Can you, I know it's a big question, but can you talk again briefly about how we move forward and where you think, based on the data, we need to focus our energy and effort?
Thanks.
And brief, because we want Jeff to have
brief
time.
Yet comprehensive.
Brief yet comprehensive.
Yes, and on our indicators, a number of our targets that we set were bold, and we did that on purpose. And I like to say even the ones that look little are bold. So making that last little bit, those last few people who are undiagnosed, to get them diagnosed, is going to take effort. To reduce that proportion homeless will take effort. So all of our indicators are bold, and we had a relatively small set of indicators because those sort of are the things that we need to be focusing on. They're representative of the major areas for our work. And moving forward in order to make that progress and scale that up, I think that's where our strategy comes in. The steps and the actions that Douglas talked about are the ways that we're going to get there by 2020 in making the progress that we need to make. And a lot of that will happen by targeting our programs and optimizing our resources, as I said. And it's this idea of focusing on the highest burden populations, the right places, and pushing forward on the right practices, so knowing and applying the
Great.
Best prevention messages.
That is a very good, comprehensive and succinct answer. So thank you. Mr. Crowley, several people have made reference to the fact that you were the director of the Office of National AIDS Policy when the initial HIV/AIDS strategy was released, and again, for that, we thank you. But that puts you in a really, I think, obvious position to share some thoughts with us about the point we've come to and where we need to get to. It's a rather philosophical question, but if you could share your perspectives, I think we'd greatly appreciate that.
Sure. Thanks, Ron. The first thing I want to say, as everybody said, is just congratulate Douglas. You know, we've been in touch over the last week a lot. Congratulations. I think I have a sense of what he's gone through. I also don't, he's been mentioned, but don't want Grant Colfax to be forgotten. I think a lot of you know our profile in some ways may be very different, but hopefully what you've seen is a consistency. And I think that speaks to the shared vision that we all have, but also the commitment of this administration that's not about one person or one office. So I want to say that. Also, Greg Millett's been acknowledged. As Douglas said about his team and Amy, I am so proud of the team I had at OMAP. But Greg Millett was my senior policy advisor, and we really, he became my indispensable partner in this. And so, while he knows nothing about what's going to come out of my mouth, I'm going to use my prerogative to say I'm speaking for both of us. So, the first thing I want to say about sort of where we're going is to look at where where we've come from, and I think it was sort of ironic that I was given the job of developing a strategy, because when the HIV community said they wanted one, I didn't believe in it. And some of you have heard me say this, but I live in Washington. I've seen all these reports released with great fanfare, and then 2 weeks later they're forgotten. I am amazed that we're sitting here 5 years later and it wasn't forgotten. So why was I proven wrong? Why was my skepticism proven wrong? And I think there's sort of, I guess the short answer is everybody played their role. I used to have a job, and Douglas does this, convey the president's deep commitment to ending the HIV epidemic. I think the president and his team have shown his deep commitment to ending the HIV epidemic. Our federal partners, and again, I'm echoing Douglas. I badly paraphrase my friend Phil Wilson when I talk about this, but he talks about very eloquently about when HIV is over and we look back, and he'll say, we'll realize we weren't all monsters, that some of us dared to care. I think if you look back on what the federal leaders in this room and the federal people that work on the HIV programs across the government that aren't here today have done over the last 5 years, is show that if you just give them a little space and support, they'll shine. And I'm really proud of what you've all done. But then to the HIV community. Douglas and I, have been advocates and other things. I am so proud of you, and I just want to say thank you, because you've done what I'm not sure I believe you could have done, and that is in some ways stay focused and support us to do some hard things. And I think that's why we're still talking about it, because you bought into this idea that some of the stuff we have to do is hard, but this is how we're going to end the epidemic. So when I think about what this update means and where we're going, I think we need to recognize that, it might be great to think we'd be at a time where we're going to announce $2 billion of more money in some flashy new program. That's not where we're at. But the way we're going to end the HIV epidemic is when we get strategic, smart, and focused, and day in and day out, do what we need to do. I think what the update does is say, okay, we've done a lot the last 5 years. The opportunities we have today didn't exist because so many of you have done hard work. But what are we going to focus on? And the strategy lays that out. Testing, PrEP, retention and care. Those are the things we need to do. The Affordable Care Act is so important. We need to use this time as we're all sort of adapting to a new world of expanded insurance coverage. Say, are we building the system so we can monitor what's going on with people with HIV and keep making refinements? That's why, I will end on this we're here on an indicators panel. One of the things that, I know I can speak for Greg in talking about is we struggled with what some of the indicators were, how many to have, and it was a tough call. Some of the indicators we had, we didn't have baseline data. But you know what? We have those baseline data now, so I think we moved it forward. You might not like every decision that this indicators team made, but when you listen to the depth of thoughtfulness they put into this, you can only be happy, because this is going to make all of our collective efforts more strategic and more effective. So again, I thank you, Doug, and your team, and I hope we can look back in 5 years and say, we really did some important work.
Great job, panelists. Great job, Jeff. Thank you all very much. Time for us to vacate the stage.